Welcome to the 2013 IBS-C moderator-led discussion entitled Putting It All Together, Current Approaches for the Clinical Management of IBS-C. This educational activity is sponsored by the France Foundation and Elsevier and is supported by an educational grant from Takeda. CME information can be found at the website www.ibsceducation.org.
Welcome to our roundtable on IBS-C and chronic constipation. I'm Doug Drossman, adjunct professor of medicine and psychiatry at the University of North Carolina, and I'm joined by two experts who will help in the discussion. Dr. William Chey, who's professor of medicine at University of Michigan, and Dr. Anthony Lembo from Harvard Medical School. Welcome.
Thank you.
Well, tonight we're going to be talking a little bit about chronic constipation and IBS-C, how we understand them, how we diagnose them, how we treat them. And why don't we start with just a basic understanding of constipation and irritable bowel syndrome. Bill, let's start with you. What is constipation? How would you define it? How do doctors define it? How do people define it?
Well, Doug, the first thing to say is it's such an important topic. It's one of these topics that's so remarkably common. You know, the background prevalence of constipation-related symptoms in the United States is estimated to be somewhere between 10 and 15%. So there are a lot of patients out there who say that they're suffering from constipation. So to your question directly, how do you define it? Well, it depends on who you're talking to. So doctors define constipation very differently than patients do. I think that we as healthcare professionals tend to focus on the issue of how often an individual is passing bowel movements. We tend to think about constipation as a disorder of reduced stool frequency. But it's fascinating that if you talk to patients about how they define constipation, that while reduced stool frequency is a problem, patients endorse a wide range of different complaints: straining, harder lumpy stools, a sensation of incomplete evacuation, sometimes even having to use their fingers to help them to expel stool from the rectum. And it's also interesting that those complaints are oftentimes felt to be more bothersome and more common than reduced stool frequency.
So there is a difference between the way patients and doctors may define it.
Oh, absolutely.
Then how do doctors try to categorize or make the definition for constipation?
Yeah, I think broadly speaking, most doctors think about constipation as a large category. I think that one of the things that people have talked about a lot is the distinction between chronic constipation and the irritable bowel syndrome with constipation or constipation predominant IBS. And the main distinction there is that patients with chronic constipation, at least by the current gold standard, the Rome 3 criteria, patients with chronic constipation or functional constipation as defined by Rome, experience constipation and little to no abdominal pain or discomfort, while patients with IBS-C really endorse abdominal pain or discomfort as one of their primary and most bothersome complaints.
Okay, well, we know that there are also different subtypes of IBS. You mentioned IBS with constipation, but there's also IBS-D. What are the differences between these subtypes?
Really, the differences in the subtypes predominantly rely upon the differences in bowel habit. So patients with constipation predominant IBS endorse more in the way of harder lumpy stools. Patients with diarrhea predominant IBS, on the other hand, really endorse more in the way of soft or loose stools. And there's that very sticky group in the middle, the tough group of IBS with a mixed bowel pattern, that is individuals that endorse both constipation and diarrhea-related complaints.
Why is it important to subtype in the first place? Why not just treat IBS?
Well, it's actually critically important to draw distinctions on the basis of subgroup, because the subgroup really dictates what diagnostic tests you do. It also dictates what therapies you're going to choose. Obviously, the kind of treatment you're going to offer a patient with predominantly constipation-related complaints is very different than the kind of therapy you're going to offer a patient with more in the way of diarrhea.
Okay, so just to summarize, in understanding chronic constipation IBS, they're differentiated basically on the presence of pain, which is more evident in IBS-C. And with IBS-C, that's only one of several subtypes, including IBS-D and IBS-M, and there may be different treatments for them, as we'll see as we go on. The other point is that patients and doctors may define it differently but we have the wrong criteria to bring it together to understand proper treatment. Tony, let's go to you and talk a little bit more about the differential diagnosis of IBS-C. I mean, how would you approach the workup of the patient? How do you evaluate a patient who comes to you with IBS-C, for example?
Well, as Bill's already gone over a lot of the symptoms that are common in IBS-C and chronic constipation, I think the first thing that a clinician needs to do is to identify those symptoms and ask patients about them, because they won't always volunteer those symptoms. So you really want to figure out how often they're going to the bathroom, what their stool frequency, consistency is like, whether they're straining, whether they're using digital maneuvers, whether there's any incontinence. So I think those are all important questions that need to be asked. Their pain, whether it's discomfort, bloating, all the symptoms that are common in these patients, and determine how severe they are, what impact they have on their quality of life. And then I always like to go back in their history and figure out, when did this all start? How many years have they had these symptoms? What was going on in their childhood? Did they have bowel issues back then? And then I'm always asking, I will ask about their family history as well. Ask if family members have IBS type symptoms. Try to determine if they've had an infection that triggered their symptoms. A lot of times patients will volunteer that an onset started after an infection. We'll talk a little bit more about that later, or after a surgery or a major traumatic life event. So those are all important things that need to be asked for a patient when you're evaluating them. And then you move on to the physical exam, and there you really want to just make sure that there isn't a secondary cause for their symptoms. And a detailed abdominal exam is important, as is a detailed rectal exam to look for dyssynergic defecation. And that is typically performed by asking the patient to bear down while doing a digital exam to assess the relaxation.
What's dyssynergic defecation?
So that's when a patient is unable to relax their pelvic floor muscles, which include the puborectalis muscle and the anal sphincter and the entire pelvic floor area. And the patient should be able to relax the muscles, and so they'll straighten their anal rectal angle. So you can assess that by asking them to simulate defecation while you're doing a digital exam.
So is that a part of IBS in terms of how you define it, or is it something else you're looking for?
Well, a lot of patients with IBS and with chronic constipation will have dyssynergia. So you do want to identify that, and many of those patients symptoms may improve by retraining their pattern of defecation to get them to relax their muscles appropriately.
So the rectal exam is really an important part of the physical exam.
It's crucial for this part, not only to assess for masses and to assess if there's any blood in the stool, but really just to look for pelvic floor functioning, yes.
Okay, well then from that point on, now I'd like to understand better. Doctors are always worried about doing tests, what the differential diagnosis is. How do you approach it after the physical exam?
So before determining which test to do, you really want to assess if they have any alarm features. Mm-hmm. And so that is part of the assessment of a patient, to determine if they're at risk for an organic disease that may explain their symptoms. So you really want to assess for any history of bleeding. You will maybe check if they're anemic, so you may be doing a blood count on some patients. You'll be assessing for family history of colorectal cancer or inflammatory bowel disease, for weight loss, for fevers. So typical alarm features that all clinicians, I think, are aware of, but you really should assess for that. And then the diagnostic tests really depend on the patient, whether they have alarm features or not, the duration of disease and the severity of disease. For me, very limited testing, I think, is actually necessary for someone who has typical IBS symptoms that's long-standing and doesn't have any alarm features. They really don't need any more testing.
You're saying limited testing. Bill, I know you've been involved in looking at celiac disease. Some people are thinking you should ask it of everybody. Others say it's not necessary. What are your thoughts on that?
Well, in regards to celiac disease, what really stimulated this discussion were a number of studies from all over the world which suggested that celiac disease was more common in individuals endorsing symptoms suggestive of IBS. In fact, in a meta-analysis that we published in the Archives of Internal Medicine a few years ago, we actually found a 4-fold increased likelihood of biopsy-proven celiac disease amongst individuals who fulfilled symptom-based criteria for IBS compared to some control population. But it's interesting that if you look at the studies from the United States, a retrospective study from Mayo Clinic and a prospective study performed by Brooks Cash and myself that we published in Gastroenterology about a year ago, It turns out that neither of the U.S. studies found an increased prevalence of celiac disease amongst individuals that fulfilled criterion for IBS. Now, does that mean that we shouldn't look for celiac disease? Absolutely not. I think celiac disease is a very important disease to look for, because it has a very defined pathophysiology as well as a defined therapy. But what physicians in the trenches need to realize is they're going to be doing a lot of testing and not finding a lot of celiac disease.
So Bill, do you differentiate whether they have IBS-C or IBS-D? Because the guidelines, the ACG guidelines, actually recommends it for IBS-D.
Yeah, that's a great question, Tony. And right now, I still think that the weight of the evidence is really for testing in patients with IBS-D and IBS-M, and not so much for IBS-C. But another important point is that the individuals that do celiac disease for a living, where the researchers that are most interested in celiac disease, oftentimes point out that 10 to 15% of new celiacs will present with constipation as one of their clinical complaints. So is it time to make a firm recommendation for IBS-C? Probably not. But would I fault somebody for thinking about celiac disease in an individual with significant bloating and constipation-related complaints? Absolutely not.
Well, it's certainly not an expensive test. The next question I really want to ask both of you, and this is for an audience of primary care and gastroenterologists, is when would you do a colonoscopy? Or in primary care, is it okay just to do a flexible sigmoidoscopy or not at all?
I mean, I think there have been several recommendations by societies, including the American College of Gastroenterology and the Colorectal Society, recommending not to do a colonoscopy in someone under the age of 50 without any alarm features. So for most patients, I don't think it is necessary. There may be individual specific reasons, if there's a family history, for example, to do it earlier, or if there's any evidence of bleeding. But the studies have suggested that the yield is very, very low and basically similar to the general population. Bill, you may want to comment on that, having done some of the work.
Yeah, absolutely. I think, there's a couple things I want to circle back to and just say a couple things briefly about alarm features. So alarm features, as Tony mentioned, rectal bleeding, a family history of colorectal cancer, inflammatory bowel disease, celiac disease, unexplained weight loss, severe progressive symptoms, some people would say is an alarm feature. Those things identify a group of patients with IBS who are at greater likelihood of having an organic basis for their disease. And I think a good way for clinicians to think about the practical utility of alarm features is in their negative predictive value. In other words, the absence of alarm features makes, in a person that fulfills symptom-based criteria for IBS, makes it exceedingly unlikely that they're going to have an organic disease. On the other hand, we all know that most of the patients with alarm features that fulfill symptom-based criteria for IBS still end up with a diagnosis of IBS. So the positive predictive value is pretty lousy, but nonetheless, I think we're obligated, or doctors are obligated, to work up very carefully individuals that endorse these different alarm features.
But you said in a point, there's a level of comfort if they have no alarm features.
Yes.
They're relatively young. Mm-hmm. And they have typical symptoms maybe defined by your own criteria.
Absolutely, and I think going back to Tony's question on the issue of the yield of colonoscopy, we published a paper on this just recently, 500 individuals with IBS, not IBS-C, but IBS-D or IBS-M, versus 500 healthy controls. And there was absolutely no difference in the likelihood of finding important organic disease like colon cancer, inflammatory bowel disease. One thing that was interesting in that population, in that cohort, because it was a diarrhea and mixed cohort, is we did find 1.5% of those individuals had microscopic colitis. Mm-hmm. So another take-home message for the clinicians in the real world is, if you send a patient for colonoscopy that has IBS-D, the gastroenterologist should definitely get random biopsies from the colon to identify the possibility of microscopic colitis.
So let me just go through a couple. What are the main things you're looking for when you have red flags? You mentioned microscopic colitis. Mm-hmm. What else are you thinking could come up when you do your colonoscopy and evaluation?
Well, the things that we're all concerned about is a cancer. Mm-hmm. So, and I know patients are concerned about colon cancer as well. So that's, I think, what's on everybody's mind. So that would be another thing. But then there are hormonal causes. I mean, we've seen hypothyroidism very rarely, so that would be another possibility as an etiology. Small intestinal bacterial overgrowth is something that's come up a lot as a possible cause of IBS. We don't recommend patients that we look for it regularly, but it is being done commonly in the by clinicians.
Okay, any others?
No, I mean, the things that people worry about a lot, but we rarely find are things like hyperparathyroidism, for example.
So these things are pretty rare. We're looking for inflammatory bowel disease, cancer, celiac disease in some cases. I mean, I think that's very important because this is a very common condition.
Yes.
And you can go on forever trying to look for so-called red herrings.
Yeah. A good way to think about this is that if you take a big number of patients with IBS and you test all of them, you're going to find stuff, right? But the take-home point is that you're not any more likely to find stuff in the IBS patients than you are in the general population in the absence of warning signs or alarm features.
And so I think where a lot of testing gets performed is when patients present with significant abdominal pain, and clinicians aren't aware of or haven't made the diagnosis of IBS, and so these patients get ultrasound, CAT scan. Sometimes we'll end up having surgery for this when there's really no significant abnormality. So I think that would be a take-home point, that you don't need to excessively work these patients up.
And there are some guidelines now about how not to do another CT scan or colonoscopy in someone with chronic pain, for example. Why don't we say something about where the research is, how we're understanding these conditions. Can you say something about the pathophysiology of IBS?
Yeah, I mean, there's a ton of work going on in IBS, and I think the foundation building blocks upon which we've thought about the pathophysiology of IBS, abnormalities in motility, abnormalities in visceral sensation, altered brain-gut interactions, and psychosocial stressors really haven't changed. But what has changed are the influences, the identification of a whole variety of different influences that can lead to those abnormalities which manifest clinically as the symptoms of IBS. So some great examples of recent research that I think highlight new and interesting ways of thinking about IBS include the whole post-infectious model, this idea that severe gastroenteritis can lead to or set a person up to developing long-standing chronic symptoms compatible with the diagnosis of IBS. And that sort of feeds into another hypothesis that's gained a lot of popularity and for which there's been a lot of research lately, and that is that patients with IBS may have alterations in the innate immune system that resides within the gastrointestinal tract, so that some of it have suggested that there's a low-grade inflammatory state. Others have said, you know what, we're not finding low-grade inflammation, but what we do find is evidence of immune activation in the GI tract. And those things dovetail very nicely with two other big concepts that are receiving a lot of attention. One is alterations in the gut microbiome. So this notion that patients with IBS have a different constituency of bacteria, if you will, that resides within the gastrointestinal tract, and those can be either qualitative changes, so differences in the types of bacteria, or quantitative changes, i.e. differences in the location of the bacteria. I think a lot of us have heard about this new theory of bacterial overgrowth as a potential cause for IBS. And then the last thing I want to touch on is the emerging role of food in functional GI disorders like IBS. I think that there's been an explosion of literature on the potential role of food and also potential strategies that involve dietary manipulation to improve IBS-related symptoms. And the last thing I'll say before I stop on this is that the listeners should make sure that they understand that these are not independent variables. All of these things that I've just talked about are codependent variables. They're literally pieces of a puzzle that probably fit together differently for each individual that suffers with IBS.
So I think it's important to summarize this point, that I think what Dr. Chey is saying is that the traditional understanding in terms of visceral hypersensitivity, in terms of motility, is really being modulated or enabled by a host of other factors that you just determined. And so we're still back to understanding it this way, but we're understanding more, and this may have implications for treatment. Tony, anything else? I'm wondering about the role of stress. Everybody says stress can affect this.
Well, I think what Bill said is spot on. That these are all these are not independent variables, but they can affect each other, and stress is the same way. So stress in a person who's at risk for it can cause worsening of their GI symptoms. So it also is important.
Yeah, and I think that the work of Giovanni Barber and others are showing that stress can have effects on the immune mucosal environment as much as on, with post-infectious IBS, stress in addition to the infection can lead to the condition.
You know, it's worth mentioning though, Doug, that the other way is probably true as well. You know, Steve Collins at McMaster has published some just fascinating work showing that if you alter the gut microbiome, you could actually change behavior and create anxiety. So by transplanting the microflora from a very calm mouse into an aggressive mouse, you can make that mouse less aggressive. By transplanting the microbiome from an aggressive mouse into a calm mouse, you can turn the calm mouse into an aggressive mouse. So
this is new information.
That's absolutely, it's going both ways.
Traditionally, we've been looking at stress models, and I think what we're really beginning to focus on is the brain-gut interaction is bidirectional, and the stigma of saying stress causes a condition needs to go away. We have to understand them as interacting with each other. Well, I think it's time to look at treatment options. What is the differentiation for treating IBS-C and constipation? You made the point about pain for IBS-C, but not necessarily for constipation. How do we focus on the treatment?
So what you said, Doug, is correct. The differentiation is the way we treat the abdominal pain. I mean, understanding that the vast majority of people who meet the Rome 3 criteria for IBS with constipation will also meet the Rome 3 criteria for chronic constipation. So the differentiating factor is treating the way we treat the pain. So in both patients, we would try to improve their bowel function. And the literature suggests that with regard to some of the more traditional therapies like fiber and osmotic laxatives or even stimulant laxatives, that the patients with chronic idiopathic constipation will have improvement in symptoms, whereas those with IBS will not have improvement in the global symptoms. They'll have improvement in bowel function, but their pain will not get better, and oftentimes may sometimes get worse. So with IBS patients, we would try to add a visceral analgesic medication, something to reduce their pain. And there we would add things like an antispasmodic. In the United States, we have several of them available. Some people would also use peppermint oil as an alternative. We could also use a tricyclic antidepressant or an SSRI or SNRI to improve their pain. Most of the best literature, and you know this best, Doug, from the studies that you've done, is with a tricyclic antidepressant to improve their pain. So those distinguishing, anything to add there, Bill?
No, not really. I mean, I think that what you said is absolutely correct, and I think the really key bit to sort of focus on is this idea that improving constipation universally improves abdominal pain. Clearly it does sometimes. There are some patients, I think all of us have had those patients, where we treat them with a laxative therapy and their constipation gets better and some of their abdominal pain gets better. But there are clearly also patients where that's not the case. And I think it's best highlighted in the literature for polyethylene glycol. You know, there's actually Tony, you're aware of this study in adolescents, 27 adolescents that were randomized, a randomized trial to look at the effects of polyethylene glycol for IBS-C. And polyethylene glycol did a great job at improving their constipation symptoms, but it did nothing for pain. And it turns out that there's also a large trial that's just been concluded or conducted in Europe in adults that shows the exact same results. So, you know, PEG does a great job at improving bowel-related complaints, but not such a good job at improving pain.
And I think you can also look at the large study that was conducted with bisacodyl in chronic idiopathic constipation. It improved their bowel function, but a large percent of patients had worsening abdominal pain as a side effect. And that's what we see clinically. And I think the IBS patients that already have pain to start oftentimes really complain much more so than the chronic idiopathic constipation.
Yeah, this is an
patients.
important point, especially in primary care. I think what we're really saying is that there is features of constipation in IBS-C and chronic constipation that can be treated in and of itself, but you have to look at other types of agents, as you've mentioned, for IBS-C, where there's a pain component. Well, that's the traditional why don't we look at some of the newer agents, because maybe some of them can affect both. What are your thoughts on some of the newer agents?
Well, there have been 2 FDA-approved treatments for IBS with constipation and chronic idiopathic constipation. The first is lubiprostone, which is a chloride channel type 2 agonist or opener, and the second is linaclotide, which is a guanylate cyclase C agonist. Both of them, again, approved for both indications, although interesting, the doses are different for chronic idiopathic constipation and IBS-C for both drugs. With linaclotide, it's actually a lower dose for chronic idiopathic constipation, 145 micrograms, and higher for IBS with constipation, 290. And it's just a reverse for lubiprostone, where it's 8 micrograms twice daily for IBS-C and 24 micrograms twice daily for chronic idiopathic constipation.
So we have to keep that in mind, don't we? Okay, is there times where you use combinations of treatments?
Yes. For patients who are particularly refractory, we do. I will oftentimes add a fiber or osmotic agent to my patients to improve their bowel function. And if their pain persists, I'll add an antispasmodic, a tricyclic, or SSRI, etc. Sometimes that'll help their symptoms. For chronic idiopathic constipation, particularly my severe patients, I'll add an osmotic agent to a stimulant laxative, for example, or if they're very severe, stimulant laxative plus one of the newer agents. But I try to use single therapy first.
So what about the effects in terms of pain with these newer agents?
Yeah, so what makes these unique is that they improve both bowel function as well as abdominal pain. In the case of linaclotide, the effects of pain maximize at somewhere between 8 and 10 to 12 weeks, where about 50% of patients will have significant relief in pain compared to about 30% with placebo. That effect seems to be less so with lubiprostone.
Okay. Well, I think maybe we should try a couple of cases. I'd like to give you some cases to see how you would be making decisions around this. Let's start with a case. This is a 42-year-old woman who was referred to you for severe constipation. Her problems began at age 16 when she began having abdominal fullness that was relieved by 1 to 2 bowel movements weekly. This persisted despite eating salads, vegetables, and bran cereals, and they caused bloating and abdominal discomfort and lower abdominal cramps and some listlessness. Oral senna laxatives and bisicodyl suppositories produce modest amounts of soft stools with temporary relief of the discomfort. But for the past 4 years, laxatives have been increasingly ineffective with production of crampy abdominal pain. Without laxatives, she even has virtually no bowel movements for as long as 10 days. There's no history of contributing medical disorders. She uses no constipating drugs and denies other medical symptoms or weight loss. Her physical exam is unremarkable except for notable abdominal fullness, particularly on the right side. An abdominal x-ray shows retained stool throughout the colon and rectum, and there's mild dilatation. Her TSH, CBC, electrolytes, and calcium studies are normal. What is your differential diagnosis at this point?
Well, she has chronic constipation. It's pretty clear. This is a pretty typical case of a young woman right around the time of puberty, having very infrequent stools with rare urge for defecation, to have colonic inertia or very slow transit constipation. So that would be, to me, would be the diagnosis.
And how would you evaluate that?
Well, I would have done a rectal exam on this woman. So I think that's what's really missing from the presentation. I would have assessed her pelvic floor, even though I don't think that that's the etiology. She doesn't have the typical symptoms of dysenergic defecation, the very infrequent stools, the straining. Oftentimes they'll sit on the toilet several times a day. And again, the physical exam is helpful there as well. She doesn't need many more. Doesn't need a colonoscopy, in my opinion. I would consider treating her first and be more aggressive with her laxatives.
When does a SITS mark come into this?
Only when they're very refractory and I'm questioning how frequently they're having bowel movements, or if I'm considering surgery, which is pretty rare.
Right, so you've got the x-ray that shows really a large amount of stool. She says she's only going every 10 days. What more could that tell you, essentially? How would you, if this is what you have, how would you treat it?
Well, I would give her more laxatives to start. I would first want to make sure that that her bowels are relatively clean. So a lot of times we'll, if the patient is willing, give them a pretty potent laxative, almost something that we give for a colonoscopy prep. So sometimes that may be some new lightly or mag citrate, and really give them a clean out of their bowel. And then start with pretty hefty doses of osmotic laxatives, see how they do with that, and then add stimulant laxatives.
Yeah, because I think sometimes the idea of going right to a medication might not work as well when you have all that stool in there too. So,
well, particularly if you're going to start with an osmotic laxative, because polyethylene glycol or milk of magnesia are the most commonly used osmotic laxatives, and they're pretty gentle laxatives. And so, if you have, it's not likely that it would have significant effects, at least not for a while, and they may get frustrated and give up on it.
anything more, or should we go to another case?
Yeah, no, I think there's a couple of other things to say. So the first thing is, to Tony's point, it's very important to explain to the patient that if you start with an osmotic laxative, which my suspicion is what most folks in primary care, and indeed I think a lot of gastroenterologists do, you have to explain that it's probably going to be 3 to 5 days before you see benefit. You know, especially in a person like this who almost certainly has slow transit constipation. So making sure you explain that up front to the patient, I think, is critical. Otherwise, they're going to be calling you. The second thing that I think is worth mentioning is, even in a patient that seems like they have slow transit, I think that there's recent data to suggest that individuals with slow transit, particularly chronically so, like this particular patient, oftentimes develop dysenergic behaviors as a consequence of straining in the setting of having their slow transit constipation. So I couldn't agree with Tony more. I would definitely do a digital rectal examination at a minimum on this patient to make sure there's no pelvic floor dysfunction.
I understand it goes the other way too, that dysenergic defecation can actually slow down transit. Is that right?
That's correct, yeah. I also think it's worth talking a little bit about fiber in this setting for the clinicians, because fiber is clearly usually the first line agent that we'll recommend for patients, particularly those with mild to moderate constipation. Here we're presenting a patient with pretty severe constipation, so the likelihood, and we suspect that it's a slow transit, and the likelihood of fiber working is very low in that subgroup of patients. It really works best in those patients with normal transit or slow or very mild to moderate constipation.
And there's also the risk of getting increased fermentation from the fiber and more bloating with slow transit, right? Why don't we try another case? This one is a little bit more complex because it was very perplexing to the primary care physician, who thought he was treating one thing and it might have been another. This is a 50-year-old woman who was referred to you with abdominal pain and constipation with episodes of diarrhea over many years. Constipation is now described as no bowel movement for several days and bloating, for which she needs to take a stimulant laxatives. Then she gets abdominal pain and straining with defecation and passes hard stools. When she has a complete bowel movement, the pain resolves. She can also have days of abdominal cramps with loose stools, even when her abdominal x-ray shows a large amount of stool in the colon. Several months ago, her local physician prescribed fiber for when she is constipated and loperamide when she has the loose stools. However, since that time, the problem has gotten worse. Despite using the loperamide combination with the fiber, she has more severe symptoms. The studies are normal and a colonoscopy was negative. What's going on here, Bill?
Well, I'll tell you, this is actually a very common scenario. At least in my practice, I see this specific scenario all the time. And I think it really highlights one of the spaces of that IBS with a mixed bowel pattern population that physicians should be aware of, because they don't really have a mixed bowel pattern. It's really that they're constipated, and this confusion over the diarrhea really occurs as a consequence of two things. One, the ability of the person after a few days of accumulating stool to purge purge stool from their colon. So this patient, like many patients, passes hard, lumpy stool initially and then seems to have what seems like diarrhea afterwards. That can either be overflow, or it could represent simply sort of a backlog of liquidy stool stuck behind a plug of very solid stool. The other thing that tends to happen is that could also be illustrated by this case is the patient starts to chase their tail through the use of interventions offered by the physician. So the physicians put the patient on fiber, presumably for a laxative effect. They've also put him on an anti-diarrheal, presumably to address what he or she thinks is diarrhea. And of course, now you've gotten the patient on a complete seesaw kind of regimen that creates this picture, or certainly exacerbates this picture of what seems like an alternating diarrhea and constipation pattern, which really is just related to constipation.
So this is very perplexing, obviously, for the doctor, and the issue is what you're saying is you're making it worse by using loperamide.
Yes, and I think that the critical piece of information that needs to be gathered by the clinician in a patient like this, in fact, in any patient that endorses both constipation and diarrhea-related complaints, is the pattern of the bowel habits. So if a person tells you that they go for a day or 2 or 3 without a bowel movement, then they pass solid stool followed by diarrhea, that is almost always from constipation. And what I tell people is this: if you have a patient like this and they come into you and they've not been in one of their recent diarrheal phases, getting a plain abdominal film can be remarkably helpful, because if you get a plain film and the patient has considerable fecal loading, you've made your diagnosis.
And what do you do with that information?
What I do with that information is the same exact thing that we talked about with that last patient that we thought had slow transit constipation. So in other words, yeah, we give them a flush and we evaluate their pelvic floor.
So this is the same scenario I actually came across last week, because we also see it very commonly, and sometimes the history is difficult. I mean, it's not always the first thing that comes to your mind, and so I actually have the patient come in to see me, and I do a digital exam. And if they have an obstruction or a fecal impaction, I've made my diagnosis. If they haven't, then I do the X-ray to see if they're obstructed more proximally, and then move forward from there. But it can be tough from just the history alone. But I agree with Bill completely on those tidbits. We tend to see this more commonly in the elderly patients, and in my patients who are on maybe on other medications, including narcotics or calcium channel blockers, that put them at a higher risk. That's where I typically see this.
Well, let me say one more thing too, Doug, and that is that this is where a stool diary can really help you. So a lot of times, and what made me think of that is your example of an elderly patient, because a lot of times they get confused and they can't recall exactly what's happened, certainly 2 weeks ago, let alone, or within the last week, let alone 2 weeks ago. And having them complete a 1 or 2 week stool diary oftentimes will make that pattern, will uncover that pattern for the clinician when the patient has difficulty recognizing it, him or herself.
Yeah, once you've cleaned them out, if it isn't a fecal impaction, it's very important that you keep them on medication so this doesn't happen, not go back and forth.
Right, obviously. You don't want to get behind again. Right. And if you think about it, using the Bristol stools form, it's very unusual to go from a type 1 to a type 7. So that might be a red flag as well.
Yeah.
Okay, let's look at a third case. This is a 30-year-old woman who comes to you for episodes of bloating, crampy abdominal pain with passage of hard stools about every other day. The pain is relieved when she has a complete bowel movement, which occurs infrequently, as often she feels she hasn't fully evacuated. She strains to have a bowel movement, and at times she needs to press on her bottom to fully empty her rectum. Her local physician has her take fiber products and Senna when she doesn't have a bowel movement for 2 or 3 days. Laboratory studies and a colonoscopy done recently were negative. So what's going on here?
Well, she fits the criteria for irritable bowel syndrome with constipation. She may have a pelvic floor dysfunction, dyssynergia, given the fact that of the digital maneuvers that she requires. So again, I guess it's been a common theme in these cases. We would do a thorough exam, rectal examination. And this patient, depending on how she responded to therapy, I would consider doing further testing of her pelvic floor with an anal rectal motility study.
What is that, and what happens if that's abnormal?
So it's not widely available, but particularly in tertiary care centers or academic centers, it is available for assessment of the pelvic floor function. So basically, the indications would be for patients with significant constipation where you're trying to exclude dysynergic defecation, or in fecal incontinence, or pre-surgical are usually the major indications for it. And basically, it assesses the pressures within the anal canal and the ability for it to relax and your ability to expel a balloon during typical maneuvers. And it's not perfect. There is overlap with normal volunteers as well. But if it's normal, it's particularly helpful. If it's abnormal, it really suggests that may be that they may have dysynergic defecation, again, in the proper patient.
Okay, and it might be possible that with treatment of that, the bowel frequency might improve as well. Well, I think that concludes our session today. We've covered a lot of ground looking at the differentiation between chronic constipation and IBS-C. I wonder if any of you have any final points or any take-home messages you'd like to give us in terms of what we've talked about. Tony?
No.
Nope. Bill?
I think that a couple of things have really struck me from our conversation. The first thing is all the new information on the pathogenesis of these disorders. And the other thing that, Tony, you touched on is this theme that kept coming up in the cases about at least thinking about the possibility of outlet obstruction constipation or dysynergic defecation. Not in everybody, by the way, but in individuals that don't respond to empiric laxative therapy. Because patients with dysynergia typically don't get better with laxatives. They need biofeedback training.
We also learned how common these conditions are, and it's going to be there. You're going to see many of these patients, and I hope we've given you some examples of how you can help understand the condition better and ultimately help your patients. Thank you.
To receive credit, please complete the attestation evaluation form found at the website www.ibsceducation.org. Thank you for watching.